Hi, we're fortunate today to be speaking with Dr. Ken Sassower, a clinician and researcher from Harvard Medical School and the Massachusetts General Hospital, who has many years of expertise in pediatric neurology, child and adult epilepsy, and sleep medicine. And we're here today to talk about sleep issues in persons with autism spectrum disorder. I'm Marvin Natowicz. I'm a professor at the Cleveland Clinic Lerner College of Medicine, and I'm staff member at the Cleveland Clinic in medical genetics and pathology. In terms of broad categories that can impact on sleep and cause sleep dysfunction, you and I had spoken previously as one way to categorize these in terms of behavioral and psychiatric, medical, and neurologic. Can you speak in terms of the category of behavioral disturbances or dysfunctions that can in turn cause sleep dysfunction in someone with autism? What are some of the things that are most important for physicians to be aware of in caring for their patients who have autism?
Yeah, in terms of behavior, that's a great question. In terms of behavioral issues, a lot of times we have to bear in mind that children on the spectrum are either nonverbal or maybe preverbal, and that may lead to frustration. Frustration not only on the part of the child, but also on the part of the parent. And those may, if you will, stress, which is such an important part of this, it's almost an inherent part of this whole interaction between parent and child. It comes out in terms of sleep issues. One of the interesting things about sleep is that you can tell a lot about what's going on in terms of daytime activity in sleep. So if, for example, if a child is stressed, it may show up in a certain way in sleep. In other words, difficulty getting to sleep or typical awakenings during the course of the nighttime. In addition, there have been studies that looked at parental stress with children on the spectrum, and it's thought that may influence a child's stress level as well. It's just sort of an inherent
So it
part
seems to me it's almost like you're breaking down the behavioral issues that can impact on sleep dysfunction. Sometimes those can be of the parent or caregiver having a behavior or a process of helping the child go to sleep that can impact on sleep function, and sometimes it can be a behavior that's inherent to the child.
Absolutely, and behaviors that are inherent to the child might be, for example, they may have perseverations with regards to, or they may have obsessional aspects or compulsive behaviors that they have, or ritualistic and repetitive behaviors that is difficult for the children to transition to regular sleep. And that may manifest as difficulties in getting to sleep. And so that becomes an important part of it. And I think that sometimes just as we all do, we want to transition from daytime life to sleep, a more calming and quiet and restorative kind of nighttime pattern. Sometimes it's hard to make that transition. So transitioning is a difficult task in everyone, but all the more so with children on the spectrum. So I think that is a good point. And then the other thing is in terms of just all the more the importance in terms of, depending on the cognitive development of the child, the understanding of what it takes to actually initiate sleep and the pattern of sleep. It becomes very important. So sometimes what we do is we often use visual schedules to show the children that this is going to be a regular pattern that's going to precede sleep. And sometimes the recommendations are to put it on various parts of the house. Like, for example, right at near the bathroom, that, okay, we're going to brush our teeth now. We're going to maybe wash our face. We're going to put on our pajamas. And there are actually visual cues of all these things. We're going to maybe put some lotion on our hands, something as a soothing kind of maneuver. We're going to have a hug and kiss goodnight, and we're going to go to bed. So maybe like 6 or 7 basic activities that are prelude to going to sleep that occur on a regular basis at a consistent time every night, so that the children can actually see, okay, this is the pattern. And okay, I am now going to brush my teeth. This must mean that bedtime is coming soon.
And what do experts in sleep medicine, such as yourself, mean when you use the phrase sleep hygiene?
Yeah, sleep hygiene. So sleep hygiene just looks at various parts of the sleep purview, if you will, and divides it into, for example, daytime habits that may impact on sleep, evening habits that may impact the sleep environment itself, and the bedtime routines. Those are usually how we subdivide sleep hygiene. So in the first category, daytime habits, what are the habits that are good to promote sleep? For example, exercise activity, not right at bedtime, but during the course of the day, so the child's able to sort of get to sleep at an appropriate time. What are avoidance of excessive caffeinated beverages? It's interesting because I was just looking at the subject in terms of how much caffeine are in our day-to-day products, but it was interesting when I was looking at just coffee ice cream, 2.5 times the caffeine content of a cola beverage. So it just gives you an idea of things that you may or may not think about in terms of the amount of caffeine. Sports drinks, very much loaded with caffeine, and proprietary blends of coffee or teas, or some of them have excessive amounts of caffeine, which can impact on the ability to get to sleep. Daytime habits. Evening habits are, once again, similar, trying to ready the child to get to sleep. What can we do? A lot has to do with this sort of somewhat of a programmed instructions in terms of, okay, I'm going to brush my teeth now, I'm going to wash my face, I'm going to put on my pajamas, I'm going to pray, I'm going to sing a song or read a book, and then I'm going to hug and kiss my parent goodnight and go to sleep. That kind of pattern becomes important to look into. Once again, keeping the sleep environment has to be sort of dark. So light at nighttime is very antithetical to sleep. So the least amount of light becomes very important. Now, some children become fearful in a darkened room, a totally darkened room. But once again, relatively speaking, the least amount of light is particularly beneficial, because children on the spectrum often have circadian rhythm problems, and can be very light sensitive, and that can impact on their sleep.
So the way you've broken it down, there are a lot of steps in the process, actually, whereby one could have a change, sometimes provided through one or more caretakers or parents, or sometimes through the action of the child, that could interfere with normal sleep hygiene and therefore interfere with normal sleep function.
That's right, absolutely. And so these are, and it's interesting because a lot of times, I know before I got into the sleep field, I never thought so much about daytime activities and how it affects the ability to get to sleep, but in fact it's extremely important. And in fact, daytime activities, even a day before, can even sometimes impact your sleep on subsequent nights. So it's very important to sort of we are in many ways a human alarm clocks, and so it becomes very important to maintain consistency in terms of going to bed and when to get up in the morning. So it's a very huge, huge issue in that way.
This is really interesting. Well, my human alarm clock would like to move on to now the general overview issue, just like you provided an overview of behavioral issues that could potentially impact on sleep function. Can you now provide a similar overview of medical conditions or medical issues that could be present in an individual with autism and that, if present, could interfere with normal sleep function?
Yes, absolutely. There are lots of medical issues that can impact on sleep function, particularly in children on the spectrum. My colleagues, Harlan Winter and Tim Bowie, in the GI department
at Mass
General, have done a lot of work on looking at conditions such as reflux, reflux esophagitis, constipation, pronounced constipation, and its impact on sleep. And it turns out that children on the spectrum have a higher incidence of reflux esophagitis, which may be for various reasons, but the notion is that, what I find interesting is that our lower esophageal sphincter tone is reduced, usually from the time around 10 p.m. to 2 a.m. as a general rule. And as a result of that, it turns out that most ulcers, for example, are actually picked up in the sort of the early part of the night, around, for example, 2 a.m. or so, as a result of this sort of alteration in GI function. And so there are lots of important clinical issues that become evident. Like, for example, so it becomes very important with regards to issues like reflux symptoms to avoid eating and going to bed right after that. There needs to be a period of time after a child eats where the gastric acids can do their thing, and so that becomes a very important issue. There are other non-GI associated issues, for example, nocturnal asthma. There are a lot of times where, for example, children may not have much wheezing during the course of the daytime, but they really manifest as hyperreactive airway disease just by awakening at night, and maybe coughing, but awakening at night. So it can be very disruptive to sleep patterns.
Getting back to the abdominal complaints or abdominal pathologies, with respect to the reflux, it might seem that in addition to appropriate timing of eating, the use of appropriate treatment of anti-reflux medication,
That's right.
might be very helpful, it would seem, in assisting the sleep dysfunction.
That's right. That's true. That's a good point as well. They tend to be very, very helpful in that way. And unfortunately, some of the newer agents that have been used over the years do not have a lot of the neuropsychiatric adverse effects that some of the older medications have had. So in a way, it's a good time in terms of anti-reflux medications.
And in addition to, you mentioned nighttime asthma and a variety of GI pathologies such as GERD or constipation, do you see, or is obstructive apnea a medical concern that you see in your clinic?
Absolutely. Absolutely. Obstructive sleep apnea is a huge issue. It's thought to occur in approximately 1 to 3% of children who are being evaluated for sleep issues. And it's a big issue, and it's sort of tied in many ways with the increase in pediatric obesity. So much so that over the years we've seen they've subdivided pediatric sleep apnea into type 1 and type 2, similar to the diabetic model, where their type 1 sleep apnea was just sort of more typical sleep apnea that was not as weight related, and usually was involved with shallow breathing, what we refer to as hypopneas sometimes on polysomnography. But they can be associated with oxygen desaturations at nighttime. They can be associated with increased wakefulness during the course of the nighttime. And it's thought that that interaction between episodic hypoxia and the sleep disruption imposed by constant awakenings at night can have an untold effect on children's daytime symptoms. And so there's lots of studies now that they're looking at the impact of pediatric sleep apnea with regards to attentional mechanisms, ability to concentrate, ability scholastically, how children do. Even the notion of pediatric obesity in and of itself, they have looked at in terms of there's a greater incidence in being left back, scholastic difficulties, just when they sort of weigh in pediatric obesity. But when you add on top of that pediatric sleep apnea, it becomes a huge issue. And a lot of times people are now thinking of them both pediatric obesity and pediatric sleep apnea as being inflammatory conditions. They may have elevated inflammatory markers, and they may dovetail with respect to a lot of children. And so now they've went from sort of more typical or classic pediatric sleep apnea to type 1, which is sort of non-obesity related, and to type 2 sleep apnea, which is obesity related. And it's found that, interestingly enough, if you look at a lot of the neurocognitive data and neurobehavioral functioning, that the children with type 1 sleep apnea who are not obese, they respond much better to remedies for sleep apnea. For example, ENT approaches,
like tonsillectomy or adenoidectomy,
adenoidectomy, absolutely, or curing or improving the nasal septum and for deviated septums. This sort of thing is much more amenable and also improves quality of life in type 1 sleep apnea. But the children with type 2 sleep apnea, who are burdened by obesity, they often don't do as well. They have a more difficult time in getting their apnea treated. And if it's treated, they often still have lingering neurocognitive issues. And particularly, there are a lot of studies that are looking at low self-esteem, and even depression is more difficult to control in that context. So it's a subtype of pediatric sleep apnea that's getting more and more notice recently, more and more press.
And among the medical issues that you've mentioned relating to sleep dysfunction, obstructive apnea, and pain from a variety of GI issues, in your own personal experience or in the medical literature, the sleep literature, is pain from other causes outside of abdominal pain, from, say, gastroesophageal reflux or from constipation, pain from other causes, sometimes a significant cause or contributor to sleep dysfunction?
Absolutely. In fact, pain from various sources is a big issue with regards to sleep dysfunction, and it could be even dental pain, sort of malocclusions, and it could be even discomfort, for example, imposed by atopic dermatitis or eczema, sort of that discomfort from this pronounced skin issues. Those impact on sleep function. And just in general, the children, for example, there have been a lot of studies on children with rheumatoid arthritis and pain associated with that, and impact on sleep. In fact, some of the early studies on sleep quality were looking at sort of rheumatoid arthritis subpopulation.
But that would seem to me to pose an especially difficult situation for the clinician, because not only is there a sleep disturbance that's caused by a medical problem, but by definition, persons with autism have an impairment in communication function. So they're not, the kids, whether they're young children or older children or adults, they're not going to have as easy a time in communicating the nature of their pain, the source, what its source is, how bad it is, and the ways it's being experienced by them. So if, for example, it's dental pain that's causing sleep dysfunction, it's going to be enormously challenging to figure that out because of the communication impairment.
Absolutely, absolutely, and I think that's actually a great point, because many of us who are in this field of autism, both in the clinical and the research sphere. I know for myself personally, I'm in this field because of Marvin Bowman, who was one of my mentors in this. And she was always, I remember her saying that there are, in many ways, you should treat children on the spectrum like other children who are not on the spectrum, insofar as they may suffer from very common maladies that may impact on sleep. But by the same token, they are unique. They are special. They have their own special features, in the sense that they can't express the pain. They can't express, I've had a lousy night's sleep. They can't express that, oh, my stomach is bothering me and I don't know what to do about it. And they're just frustrated. And that frustration is, often peels over to families, to siblings, to parents. It becomes a major source of not only frustration, but then sleep dysfunction. My child didn't sleep last night. I haven't slept a wink. And when you think about this on a sort of a massive scale, we are a sleep-deprived nation, and particularly all the more so in this context, that the children aren't sleeping, the parents aren't sleeping, family members aren't sleeping, the society isn't sleeping. It's impacting work production for these frazzled family members who then have to go to work and function. And it's just, and so it's a huge issue on so many different levels.
So, given the enormous significance of sleep dysfunction, both for affected individuals and for their affected families, what do you, as an expert in the field, feel are the most salient clinical research issues? And what do you, as an expert in the field, feel are the most salient basic research issues regarding sleep disturbances in persons with autism?
Yeah, well, I would say that there's so many clinical research issues. I'm a neurologist, I'm a neurophysiologist, so I really study sort of brainwave function, if you will, and there are lots of issues. For example, we know that there are, even the work with Dr. Bowman that we have done over the years, we have noted that there are lots of REM-related abnormalities in children on the spectrum in terms of their sleep function. But we don't know the significance of it quite yet. So, for example, it's been written that children have either diminished stage REM sleep percentages or disrupted REM sleep, or an absence of the regular progression of stage REM sleep. It's felt, for example, that the first half of the night there's a minimum amount of REM sleep, and as the night progresses, there are increasing amounts of REM sleep. And a lot of times the children on the spectrum don't fall into that category. And so a better understanding of that will be particularly helpful, because so much of learning and memory function has to do with the stability of our stage REM sleep. Shura Buckley and I, we sort of studied this a few years back, looking at REM enhancers, medications like donepezil, looking at in terms of children on the spectrum who were REM sleep deprived. And then we actually wound up giving them anticholinesterase inhibitor to help improve REM function or REM percentage, I should say. And we were able to do that relatively successfully, but we don't know the next step. What does that mean in terms, are children better able to learn as a result of that? Are they be able to function better in society as a result? So there's a big gap that way. Another form of clinical research that we've done with Gregory Barnes and Beth Mallow, we're looking at interictal EG discharges in children on the spectrum. It's said that up to 45% of children on the spectrum may have abnormal EEG discharges. We don't know the full gamut of what that means, in the sense that there are some children whose nighttime sleep is bombarded with diffuse spike wave discharges. We call that condition continuous spike wave discharges during slow sleep. It has a very long moniker, but it really suggests that when children go to sleep, their brain is bombarded by these diffuse spike wave discharges that can be upwards of 85 to 90% of their sleep recording. So one might say, well, gee, I don't know what one spike does during the course of the nighttime or a few spikes, but when your entire sleep record is bombarded by these diffuse spike wave discharges, it becomes another entire entity. And these children are often associated with having autistic features, having speech and language developmental delay. They often have lots of neurobehavioral abnormalities. So trying to hone in on the relationship between a lot of what we see, for example, on brainwave monitoring, and sort of then tying that into the actual clinical sphere. How does this affect the presence of these spike wave discharges? How do they affect next day behavior, cognition, mood? That's a huge issue, and I think an area ripe for research. And then in terms of the basic science issues, we just sort of, what I refer to as, we have a hint of some of the abnormalities that may be important in terms of basic science issues in sleep for children on the spectrum. For example, we know, or we at least surmise, that there's some abnormality in melatonin. There are some studies to look at altered melatonin metabolism, urinary metabolites, like, for example, 6-sulfoxy melatonin is abnormal in certain children on the spectrum, but we don't know the full gamut in terms of how important is that. Is that a clue, clinical clue? Can that become a clinical clue over time? Is it a common feature to all children on the spectrum, or just a slice? Who is affected by some of these melatonin abnormalities? Or, for example, there are serotonergic dysfunction. For example, when you look at the platelets of children on the spectrum, they're thought to have altered serotonin metabolites as well. So the question is, where does this all fall into in terms of how does this all translate into, there's still pieces of the puzzle we still need to know, for example, and that's important. And knowing that, for example, that how serotonin metabolites then elaborate into melatonin. That becomes, and we know that melatonin is somehow impacted. It might be important to sort of hone in better on these very basic neurochemical areas of dysfunction in children on the spectrum.
Thank you very much. Appreciate taking so much time to help us understand these important sleep issues in persons with autism.
Thank you.
This concludes our second film session on sleep issues in persons with autism spectrum disorder, where Dr. Sassower has reviewed the large number of behavioral, neurological, and medical conditions that can impact on sleep function in persons with autism. Thank you very much, Dr. Sassower.